I'd like to welcome you to the national award-winning PRS Journal Club podcast. With your hosts, Dr. Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the PRS Journal Club podcast.
Hi, everyone, and welcome to the January 2019 edition of PRS Journal Club podcast. I am Lily Mundy, PRS Resident Ambassador from Duke University, and I'm joined by my co-resident ambassadors, Raj Parikh from the University of Washington in St. Louis, and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. Sheri Slezak, Professor of Surgery at the University of Maryland School of Medicine and Chief of the Division of Plastic Surgery at the University of Maryland Medical Center. Thank you so much for joining us, Dr. Slezak, for this PRS Journal Club podcast.
Thank you for having me.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The next article that we will discuss is entitled An Analysis of Differences in the Number of Children for Female and Male Plastic Surgeons. This is an article by a multi-institutional group led by first author Dr. Heather Furnas from Stanford University. The authors start the paper by discussing gender distribution in medical training, citing that medical schools are now over 50% female. However, plastic surgery residencies continue to be 1/3 female and 2/3 male, suggesting that something is preventing more females from entering into a career in plastic surgery. The authors hypothesize that a factor in this gender disparity in plastic surgery training is a fear of how to navigate a demanding surgical training program with the potential desire to have and raise children, primarily for aspiring female plastic surgeons. And while reproductive challenges for women in plastic surgery have been identified in previous articles, the degree to which women are uniquely impacted in comparison to male colleagues has not yet been established. To further explore this issue, the authors performed a cross-sectional survey of ASPS members and candidate members comparing reproductive outcomes, including number of children, factors impacting decision-making for family planning, and complications associated with pregnancy and childbirth to identify disparities between female and male plastic surgeons. 757 plastic surgeons responded to the survey with a response rate of 15%. The authors found that 45% of female plastic surgeons did not have biologic children, in comparison to 23% of male plastic surgeons. Additionally, 73% of women delayed having children due to the demands of training, in comparison to only 39% of their male colleagues. Twice as many women experienced infertility, and lastly, within plastic surgeons without children, women were 11 times more likely to say they didn't want children in comparison to men, possibly suggestive that maybe there is a selection bias to females entering plastic surgery training. Overall, the authors identified significant differences in family planning and reproductive outcomes in comparing female and male plastic surgeons and trainees, with less female residents having children in their careers than their male counterparts. The authors suggested that poor institutional maternity support may be a factor in this, and they advocate for a universal comprehensive parental leave policy, in addition to better support for childcare and improved breastfeeding resources. They concluded that in order to train and retain high-quality female plastic surgeons, as opposed to only women who aren't interested in or willing to give up childbearing for a career in plastic surgery, navigating the challenges of supporting females in this aspect of their life is important. Limitations to the study included a low response rate of 15%. However, this is comparable to similar surveys of ASPS members, and a disproportionate number of female response rates, which the authors statistically adjusted for. I think that the results of the study show that while we've made progress from the extreme gender disparities and previously reported high elective abortion rates of women in training, there are still disparities in both the support women feel as well as the actual reproductive outcomes. One of the reasons that I had selected this article is pregnancy within training has become commonplace in my residency program. Here at Duke, we had our first female resident pregnancy in the history of our program around 5 years ago. However, now within the past 2 years, we've had 4 additional female residents become pregnant, myself included. Around 3 years ago, when it was clear that there were several female residents that would likely become pregnant in the coming years, there was a palpable anxiety surrounding this. Now that so many of us have had children and it hasn't really had a significant impact on other residents, I think the stigma around it has started to fade here. I hope, at least here at Duke, this trend will continue both within my program as well as programs across the country. Over time, hopefully, medical students will start to experience this cultural shift, and potentially the desire to have children will become less impactful on the student's decision about the specialty. Dr. Slezak, I'd like to start our discussion, and I'm curious to your thoughts on the article, especially in your role as the chair of plastic surgery at the University of Maryland. Do you think that the cultural shift we have started to see here at Duke speaks to what will hopefully become a national trend, or what has been your experience at your home institution?
Yes, I think it's a rapidly changing environment, as it should be. Remember that I trained back in the dark ages, and you had to do general surgery first, to get in a good program. There was no match. And when I interviewed, I was told outright by the attendings that you could never have babies or toddlers and be in this program. And they told me that I was their number one candidate and sent me to lunch with the secretary. And I didn't think they'd take me, so I made some arrangements to do a year of research because I really just wanted to have a baby. I'd finished general surgery and I was 31 and I wanted to have a child. So when they called me and gave me the position, I asked for a deferment and I just lied. I told them I was really interested in research and I just wanted to have a child. So you had to hide it back then. And nowadays, I'm glad to see that that's not an issue at all. I've hired 3 women faculty here. We've had 4 pregnancies in the last few years, and it's just a part of the program. We plan for it, and it's a great event. And I wanted them to hear, when they first told me that they were pregnant, congratulations, that's wonderful news, instead of the stuff that I heard, that you can't have babies or toddlers.
Yeah. And that was definitely my experience here at Duke. And as you mentioned, it's really very reassuring and comforting for that to be the response when you're telling, your program director or your chairman.
Remember, this is also a big change for men, because when I trained, if the men were having a baby, they didn't get any time off at all. They were back at work the next day. So it's tremendous progress for both males and females.
Kyle and Raj, I'm curious to what your thoughts are about the article and sort of how things have been at your home institutions and if your programs have been similarly going through a transition.
It's always good to have hard data, even if it is just from survey, because it now kind of puts the issue and the disparity out there on paper with numbers so we can see kind of the differences. Like Dr. Slezak mentioned, kind of the dark ages. You think about that now, and it sounds crazy that surgical residents would choose or be coerced almost into having elective abortions so they could continue their training. And so clearly we're in a better place today than we were back then. And as far as our institution, we've had residents have babies. It hasn't been a huge issue. They usually have it towards the end of their training when they have less service obligations to begin with. We haven't had really any problems with it. I think Dr. Slezak brings up a good point on paternity leave. It's something that's starting to grow. We've had a couple of our chiefs the last couple of years have had kids, and they're taking, a week or 2 off, as opposed to historically when I first started, people would maybe be there for like the actual birth and the next morning they were rounding or doing cases. So I think it's definitely shifting towards a more parental involvement and having another side of life besides just residency.
Thanks, Kyle. I agree. I think at our institution, it's been really just part of the culture for as long as I've been here, and I imagine a long time before that. We have Dr. McKinnon is our chairwoman, and our program director is also Dr. Marissa Tenenbaum. So we have a female chairman, female program director, and we've had over 50% female faculty for at least the last 10 to 15 years, as well as over 50% female trainees. And since I've been here, we've always had female residents who've gotten pregnant in residency. Some have taken time off either through the lab to do research, and some have just gone straight through. And we've also had male residents whose spouses and significant others have had kids. And it really is just part of our culture here, and it has not been a significant issue. With that said, though, I do think in some of the other specialties at our institution, specifically orthopedics and neurosurgery, that it still does remain a significant burden and challenge. And you talk to your friends kind of across the surgical specialties, and there still is that stigma that Dr. Furnas talked about in this article. And that if you look at one of the tables, when you talk about on supporting a pregnant co-resident, I believe it's table 4, I think some of those quotes are just really shocking to me to look at, both from when they queried the women and the men. And I'll just read a couple of them because it says, unless things have changed in the last 25 years, it's unfair to place a burden on other residents of planning to have a child. That's a quote from a woman surgeon. Another one is, it's okay if there's a large number of residents in a program, but most residencies are too small and it's not fair to place an unfair amount of work on other residents. So I do think that obviously there's still a stigma. And even though we're currently in training and we're seeing progress, I do think there's still a significant issue, and maybe it's just we're not seeing it clearly at our institutions, but I do think if you look nationally, similar to what Dr. Furnas found in this paper, that you will see that there's still a lot of ground to make up.
This is Dr. Slezak. Do you think the 80-hour work week limitations have helped with some of that?
This is Lily. I think it's a little hard, at least for me, to feel that I can answer that question since I have always trained within this mindset of the 80-hour work week. I think at least in speaking with people who've trained prior to this, I think it's been maybe in combination with or part of the starting to sort of have just a general cultural shift and change and this thought that residents should have a balanced life and should have life outside of the hospital, and it's okay for them to have outside interests. And so I think from that perspective, it definitely makes it easier to have a home life. But again, it's hard for me to sort of answer that since I was never training in that previous model.
Well, I was thinking that that would protect somebody from having to take someone else's call who's on maternity leave because you still couldn't violate the 80-hour work week.
I see what you're saying. Yes.
I definitely think that's played a role in it too. And I think it's also understanding, just having co-residents, whether they're male or female, have an understanding that even though like this is someone is pregnant, that's just, it's just for a few months of where you may have to work slightly longer or you may have to cover some shifts that you wouldn't have originally covered. But as long as the understanding is that, you're in training for at least 6 years, if you're in an integrated program now, in some programs 7 years, that if you have a good relationship with your co-residents and it's a give and take and things come up even in life that aren't pregnancy that require your co-residents to cover for you or to work a little more at some point during those 6 years. And I think at least at our institution, we just view it as just everybody's on the same team. And sometimes people have to pitch in a little more and then sometimes you pitch in a little less.
I think things have also improved in that every hospital and program now has, a maternity and a paternity leave program, a birth recovery policy, so that you do know upfront what you can do. The American Board of Plastic Surgery has recently granted 2 more weeks that are possible to have off in those last 2 years of training. And the ACGME, with the new regulations that are coming out next July, there needs to be lactation stations, refrigeration. You have to have flexibility for medical appointments, for pediatric appointments. So there's been a lot of progress. We still need more, but it's getting so much better.
Kyle here. So I was thinking when you say the steps that the American Board of Plastic Surgery has made to kind of have some of these guiding principles for paternity and maternity leave, but I wondered if you could comment if you think there could ever be any kind of unintended negative consequences to this, i.e. where the programs like Lily mentioned, well, we're really worried about like taking 2 or 3 females or 2 females in a class of, if we only can take 2 residents, what if they both get pregnant or things like that, where they self-impose a quota so they don't have residents getting pregnant at the same time, or things that could significantly alter the logistics of the program and the service requirements for residents. What are your thoughts?
Well, it is true that pregnancy, can be a scheduling dilemma for the program director. But, with some planning and some shifting of rotations, I think it's usually not a problem. And I have not seen any programs or heard anybody voice concern about, having a certain number of women. So I think that we're beyond that. And it may change again as we move into competency-based evaluations, in that, some people may need only 5 years to completely complete all of their training and be technically competent, whereas others may need more. So there may be some flexibility in that also.
Transitioning a little bit into pregnancy and starting a family as a junior faculty member, what sort of advice have you given to your junior faculty members that you've hired, or what sort of advice would you offer to those of us thinking about family planning sort of either in residency or in the beginning of our early attending life? Do you think there's sort of different things that we should be thinking about, or pros and cons as when we're sort of contemplating our own family planning decisions?
When I have new faculty, if they're women or men, in fact, I say, and we are a very family-friendly place. We have a maternity and paternity policy. I give that to them. It will be not a problem if you choose to be out on maternity or paternity leave, and just tell them it's okay. Male or female, the birth of a child is a wonderful event in your life, and we should all celebrate with each other.
Have you run into any difficulties with block time or, sort of referral patterns for some of your junior faculty members if they've taken time, sort of taken a couple months off for maternity leave?
No, we would just cover that and cover their practice or their hospital rotations during that time. And that's not been a problem. And I think the studies even in business show that when a person comes back from a maternity or paternity leave, they're busy, and within months they are more productive than ever and make up some of that time that they were off economically. So it's really not a detriment at all.
Yeah, that's really wonderful, at least for us to hear. Kyle and Raj, I don't know if you guys had any other thoughts on the article or the topic in general.
This is Raj. One of the things I did want to ask, because it comes up a lot when I talk to my co-residents, and then you talk to even some of the male residents that have female spouses that are also in the surgical fields. And do you think there's an ideal time to have children? And obviously everyone's life is different and there's different considerations to take into place. But just broadly speaking, as a female plastic surgery trainee or entering into practice, do you think there's a time that's more ideal than less ideal? For example, there's often fear if you wait until you're starting your practice, if you're not in an academic practice, that your partners may not cover you and you may not be compensated for that time that you're off, versus doing it in residency, where obviously there's still at some places the stigma. However, you do have at least some protection as far as coverage goes.
Kyle, did you have any other thoughts you wanted to share?
I think Dr. Slezak kind of hit it on the head in terms of perhaps not specifically, our generation is kind of transitioning, but probably the residents that we train, it will just be like commonplace that it was, you kind of have your family life and plastic surgery is a part of that. Whereas perhaps historically, at least with some of the more senior faculty that we work with, plastic surgery is your life. You're making sacrifices. They made sacrifices. You should do the same thing. So I think it's just going to continue to evolve as residents go through training programs and think that and understand that plastic surgery is part of their life as opposed to encompassing all of their life. But I thank Dr. Slezak for bringing up that point.
Thank you. Dr. Slezak, any closing thoughts on this article?
I think that you should plan your family as it works best for you. And even if you have to take some extra weeks in training, this is a small percentage of the time that you will spend in plastic surgery, and your children will give you joy for many, many, many years. So you should just do what is best for you.
Well, thank you. And I think with that, we'll end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune in to the other two articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected article authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already, as it is there where our monthly journal club takes place. And once again, thank you so much, Dr. Slezak, for joining us today. We really appreciate having you here.
Thank you for having me.